Good morning again. Thank you for joining us. We hope you enjoy your company. We'd like to encourage you to stay with us till the very end of today to get the Minister of Health will be addressing some recommendations on how to move forward. Another thing is you will find QR codes on your table. This is for the evaluation form. We'd highly appreciate it if you could just fill that evaluation form by the end of today. Thank you very much, and please join me in welcoming Dr. Qusai who will be moderating this very important session.
Thank you. Good morning. I know they like to have a break, so if you want to take some more time, you can cut it from the lunch. But they told me already that lunch breaks then already cut. It's very complex. Anyway, it's my pleasure to introduce the first speaker today, our speaker, Dr. Rasha Odeh. She is a pediatric endocrinologist here at Jordan University, University of Jordan. So please welcome Dr. Rasha Odeh.
Thank you, Dr. Qusai, for your introduction, and thank you for inviting me today to speak about an important issue that's childhood obesity. This is really a challenging issue that is being recognized as one of the most important public health problems in the world right now. And with its consequences and comorbidities, we as healthcare providers should identify children who suffer from this problem to tackle it in a timely manner way. As you can see in this map, the world prevalence of childhood overweight and obesity is affecting many, many countries. And the developing countries have empty areas where we don't know exactly what is the burden of obesity in many developing countries. In Jordan, we have a very nice study coming from the University of Jordan by Dr. Al-Nawaiseh and the medical students, where they looked at, on a national level, the prevalence of short stature, underweight, overweight, and obesity among school children in Jordan. It was a cross-sectional study involving around 3,000 children between 6 and 17 years old. And they looked into all areas of Jordan, south, center, and north. And they also had a sample covering the private schools and the public schools. What they found was interesting. Found that obesity rate was about 15.7%, and it was more prevalent in the central towns and in private schools. It was more prevalent between males. Overweight was more prevalent in females, but the overall rate of overweight was 17.3%. So the total percentage of obesity and overweight in children in this sample was around 33%. This is a huge number. We also know that after the COVID era, many reports came out describing an increased rates of obesity among children. And this questionnaire-based study, also from Jordan, shows that there's an increase in the BMI Z-score between children and adolescents in males and females after the COVID-19 lockdown. So who is an obese or an overweight child? We should know these definitions in order to address or recognize these children. And we all know the equation of BMI, but in children we have to plot the BMI on the standards that are gender and age-related. Any child whose BMI is above the 85th percentile and below the 95th percentile is an overweight child, and any child who is above the 95th percentile is an obese child. We can go further and define severe obesity or class 2 or greater obesity if the BMI is above the 120%
of the 95th percentile, or if it is more than 35 kilograms per meter square, whichever is lower. These definitions are very important because they are different from adult numbers. Why are we concerned about obesity in children? Because it's a health damaging issue. It has many comorbidities and complications. It affects every single organ and system in the children's body. So if we are talking about neurological, it can cause increased intracranial pressure. It can cause high blood pressure, dyslipidemias, cardiac issues. Endocrine, it can cause PCOS and type 2 diabetes, of course, preceded by insulin resistance. It also can cause many GI problems. Most importantly is the non-alcoholic fatty liver disease or fatty liver. It can cause obstructive sleep apnea. The children will not sleep well because of their increased weight. And it affects their psychosocial situation. So when we look at the health-related quality of life in children, it involves the children's physical, emotional, social, and school functioning. And this study, which looked at the health-related quality of life in severely obese children and adolescents, it showed that their quality of life is really poor. That we know that historically the worst health-related quality of life was reported in children or adolescents who were diagnosed with cancer and were already receiving chemotherapy. And in this study, they showed that severely obese children and adolescents, they have lower health-related quality of life than children and adolescents who are healthy, and it's similar to those who are diagnosed as having cancer. So it does not only affect their health, but also their mental health. So what is the etiology of obesity? Why do children get obese? There are many, many, many factors. There's not one single factor. But there are major ones that we can modify, and there are things that we cannot modify. So environmental factors are the ones that are modifiable, the ones that we have to concentrate on. There are endocrine causes, genetic causes, drug-induced, and there's what we call metabolic programming or epigenetic causes. We all know now that we are living in a situation where high dense calorie, high palatable food, easily accessible food is available to children, and also they have also less energy expenditure in terms of sitting many, many hours in front of screens, not doing any kind of exercise. And this imbalance between energy intake and energy expenditure would lead to obesity. But we also know that many people would maybe eat the same amount of calories, but some people will gain weight and others will not gain weight in the same way. So there are other factors that define that, and these are maybe genetics, because identical twin studies showed that twins who are identical and were separated at birth, they had similar weights even if they were separated, and that identical twins, if they are exposed to the same environment of overeating, they will increase weight in the same way. And also the weight of adopted children is similar to the biological parents rather than their adoptees. So 40 to 70% of the difference in the weight between two people is due to differences in their genes. So we cannot change genes, but we can change environment. That's why we have to concentrate on what's happening in our societies in this time of life. Many discoveries have been seen in this century regarding the genetics of obesity, and we know that there is a pathway in between the gut and the brain that tells you that you are now satisfied, you don't need to eat more. That's called the leptin MC4 pathway. And we also defined genes that when they are deficient, the child will have no satiety whatsoever and will be hyperphagic. The idea of this, to mention this, is if you have a child who is having an early onset obesity before the age of 5 years and acting as he is not has no satiety whatsoever and hyperphagic, look for a genetic cause, please. Also, what's more common is that we have multifactorial or polygenic predisposition to obesity. It's not a single gene usually. So if you inherit a group of genes that makes you more prone to be an obese person, you will add weight more as an adult. And that was found in this study that looked into 200,000 person with around 2 million alleles that are associated with either increased weight gain or low weight alleles. And if you have the high weight alleles, you are more prone to be an obese person. Also, as pediatricians, we also have to define those with syndromes that are associated with obesity. So if you have a child with any dysmorphic feature, any child with developmental delay, please refer to the pediatrician so that we can identify the cause of this obesity as part of a syndrome, like Prader-Willi syndrome, Bardet-Biedl syndrome. Endocrine causes of obesity. There are many endocrine problems that can cause obesity, such as hypothyroidism. This is one of the common things that we see. A tip for you to understand that this obesity is of an endocrine cause or maybe a syndromic cause is that the child is obese and short. Because children who are obese and tall, they usually have the imbalance between nutrition and energy expenditure. So having a child who is obese and short should alert the person to investigate more for an endocrine cause. This is a very complex slide to tell you that if we have a child with obesity, we have to go through all these causes maybe, but usually what we end up with is the imbalance between nutrition and energy expenditure. This is the most common cause. Then, when we identify the child with obesity or overweight, we have to screen for comorbidities. And how do we do that? We screen for diabetes or prediabetes by hemoglobin A1C and oral glucose tolerance test. We have to also measure the blood pressure, the lipid profile, so that we can see the normal values in comparison to age-specific normal values. We have to look for liver enzymes for the hepatic steatosis and the PCOS. Of course, not to forget the psychiatric background. Treatment is the most difficult part because once you reach the stage of obesity, treating it is really, really difficult. And it always starts with the self-directed lifestyle modification or the professionally directed lifestyle modification. If these fail, we might need to go to pharmacotherapy, and we sometimes really need to go to bariatric surgery, especially if we have comorbidities. So if we look at the treatment, the guidelines statements coming from the Endocrine Society says that intensive lifestyle program is the first thing to be done, and pharmacotherapy is only after this formal intensive lifestyle program fails. And these medications are really limited. They are really, they have many side effects, and we can't use them at all ages. They are specific for certain indications and for certain age groups. They only should be prescribed by someone who has experience in prescribing obesity medications for an obese child. Not everyone should embark on this treatment. As for bariatric surgery, this is also a choice for severely obese children with their BMI above 40 or 35 with significant comorbidity. And the guidelines also advocate that we don't go for that until they reach Tanner stage 4 or 5. That means they reach their end height or maturity, while the American Society of Bariatric Surgery says that this is not a limitation, so there's some kind of controversy between the two societies. Now, in this last slide, I would like to say that treating obesity is really difficult, and if you manage to have some kind of decrement in the weight, it's difficult to also maintain. So please have in mind that prevention is key. And prevention is only, or can be done only by the, as I said, the modifiable factors, the food, the exercise, and the screen time. One of the many things that when we ask families about their feeding habits or their food habits at home, one of the common phrases that comes back from families is that I don't want to deprive my child from delicious things. This is a very common statement. So the culture is really biased because they think that taking away juices and junk food is deprivement. So the idea is really stuck in the minds of parents in a very wrongful way, and we have to change that. And with that, I thank you.
Well, thank you very much, Dr. Rasha, for a nice talk. Our next speaker would be Dr. Asma Basha. She is Professor of Obstetrics and Gynecology at Jordan University. So it's our pleasure to have her for the next talk.
Thank you, and good morning, everyone. My talk will be about maternal obesity. As we see in previous lectures, that maternal obesity is a global obesity is a global pandemic and epidemic, and it is a major health issue in Jordan. Can I go back? Okay. It leads to a range of non-communicable diseases as diabetes, various cancer, hypertension, and cardiovascular disease. It is a significant public health issue. Sorry for that. We have an alarming high and increasing prevalence of diabetes in Jordan in males and females, and even schoolgirls are having overweight and obesity. So obesity is a major health component in Jordan. What is the impact of obesity on women's life? There is earlier onset of puberty, increased pregnancy complications with neonatal and childhood consequences, increased endometrial polyps and menstrual irregularity, increased urinary incontinence and pelvic organ prolapse. Obesity increased the phenotypic expression of polycystic ovary syndrome, and it decreases the efficacy of hormonal contraception. It is also closely associated with reduced fertility, and there is an increase in the incidence of uterine, ovarian, and breast cancer. So, high pre-pregnancy BMI also is associated with an increase in severe maternal morbidity and mortality. During pregnancy, there is increase of recurrent miscarriages, gestational diabetes, gestational hypertension and preeclampsia, preterm labor and delivery, venous thromboembolism, pelvic pain, obstructive sleep apnea, chest infection, genital and urinary tract infection, pulmonary embolism, prolonged postnatal stay, and increase in the incidence of maternal mortality. Also, during labor, there is increased rate of augmentation, increased rate of dysfunctional uterine contractions and failed induction, increased cephalopelvic disproportion, increased incidence of operative delivery and post-operative complications and wound infection, increased anesthetic complication, and increased postpartum anemia, depression, and weight retention. For the infants, there is increased. This is just maternal obesity without diabetes or gestational diabetes. There is increased incidence of structural anomaly, mainly neural tube defect, macrosomia and shoulder dystocia, which is difficulty in delivery of the shoulders of the fetus or neonate, prematurity, electrolyte imbalance with increased admission to NICU, intrauterine growth retardation, and increased incidence of perinatal mortality and morbidity. For future offsprings, there is a risk, as we heard before, risk of obesity, metabolic and cardiovascular disorders, risk of neurological disease, asthma, autism, attention deficit, hyperactivity disorders, eating disorders, and propensity for reward-driven behavior. Maternal obesity is associated with hyperphagia. Hyperphagia will alter the satiety center in the fetus and will change the developing hypothalamus, and it will cause defective feeding regulation in adulthood, resulting in permanent changes to hypothalamic structure and function, as Dr. Rasha mentioned. Exposure during the early stages of life which we called obesogenic factors اللي هم free fatty acids which are increased, high glucose levels, and insulin has been shown to cause epigenetic modification which can persist and be inherited all through the coming generations. So maternal overnutrition, high-fat diet will cause DNA methylation, histone modification, and non-coding RNAs, which will cause permanent changes in organ structures, cell numbers, and metabolism. Changes can be transient or can be permanent and can be inherited for future, again, generations. Also, obese pregnant women, when they deliver, they have problems in initiation and in continuation of breastfeeding. But we need to encourage them to breastfeed because of a lot of benefits from breast milk, which we all know. We published a study in the International Journal of Diabetes in Developing Countries. It was about the prevalence of gestational diabetes and contributing factors among pregnant women in 2019, which we studied 644 women, and the prevalence was high. And the main contributing factors for gestational diabetes was increased pre-pregnancy BMI and increased BMI at the time of the test, which is between 24 to 28 weeks gestation. Also, prevalence was increased due to the presence of first-degree family history of diabetes mellitus type 2, presence of, if the mother is having increased gravidity and parity, and for women with advanced maternal age and history of previous gestational diabetes in other pregnancies. So hyperglycemia is a major public issue and the most common medical disorder in women worldwide. And GDM has emerged as a marker for future type 2 diabetes and cardiovascular problem. Nearly 45% of women of childbearing age with type 2 diabetes mellitus remain undiagnosed. If we talk about the MENA region has a high prevalence of overweight and obesity among women above the age of 20. And more than 50% again of women are likely to become pregnant with either diabetes mellitus undiagnosed or improperly screened. Undiagnosed or uncontrolled or inadequately treated hyperglycemia in pregnancy possess an increased short and long-term maternal, fetal, and newborn morbidity. And there is lack of consensus among international health organizations on screening and diagnosis of this problem. And healthcare professionals are confused with various guidelines offering conflicting and confusing recommendations. So there was a need to have guidelines for the MENA region for management of hyperglycemia in pregnancy. A guideline committee was formed in August 2020 during the COVID pandemic, which comprised members from different countries in the MENA region. These members were from different specialties: obstetrician, gynecologist, endocrinologist, neonatologist, internist, and diabetic education, with interest and for developing the guidelines for the MENA region for hyperglycemia in pregnancy. There was about 25 virtual meetings every weekend for 2 to 3 hours with active participation. And the first meeting started in September 2020. And after 7 months, the guidelines were completed and ready for publication. And it was published in JNIL of Diabetology in 2021. From Jordan, there was Nadima Shukum, who is the director for the Diabetic Society in Jordan, with Dr. Iman Badran and me. This guidelines is a practical and comprehensive guidelines. It addresses all aspects of care for pregnant women with hyperglycemia, both GDM and previous type 1 or type 2, covers preconception management, antenatal management, intrapartum care, postpartum management, neonatal care, and breastfeeding. It addresses contraception, care of women with fetal loss, and management of complication of diabetes. And it includes clear instruction for insulin administration, techniques, storage, and guidelines. It explains medical nutritional therapy, including caloric requirements, common food types of MENA region with their glycemic index, and concept of food plate. It gives clear recommendation for exercise, including types and duration. It recommends universal early screening for 2 hours, 75 gram oral glucose test, and the diagnostic criteria which is followed by WHO. And it advises for sequential blood glucose screening in the 2nd and 3rd trimester in order not to miss any woman with gestational diabetes. Preconceptional care is recommended, effective contraception is advised, and to be long-acting reversible contraception until the hemoglobin A1C is within normal range. They focus on optimizing blood glucose control, initially by lifestyle modification, as I said, by exercise and medical nutrition. If they failed after 1 to 2 weeks, so another medications can be added. And it advises follow-up after delivery for the whole life of the woman, in order to decrease the prevalence of type 2 diabetes and its complication. And they advise for early screening with strict glycemic control during pregnancy and post-delivery, timely identification, screening, and diagnosis and intervention to control hyperglycemia in pregnancy will not only reduce short and long-term maternal and neonatal morbidity and mortality, but it will also improve quality of life and prove to be cost-effective and will reduce the future burden of type 2 diabetes and obesity. In May 2021, we found that all the data were condensed in that guidelines. So Nadima Shukum from Jordan, she came with the idea of writing a book, and the book was published and launched in March 2022. The name of the book was Diabetes and Pregnancy, A Journey into the Past, Present, and Future of Care. So at the end, we conclude that pregnancy offers a unique opportunity not to be missed for the primary prevention of the adverse consequences of hyperglycemia through patient education of lifestyle modification, continued blood glucose monitoring practice, and follow-up post-delivery. Well-defined program to control and prevent obesity as well as intersectoral action are urgently required to reverse current trends. And the most important thing is women's well-being determines the health of the next generation and can help improve future public health for individuals, families, and communities. Thank you.
Well, thank you, Dr. Odeh, Dr. Basha, for the nice talk. And last but not least, we have the third speaker, Dr. Hala Al-Nawaiseh. She is Assistant Professor of Nutrition and Epidemiology at the Department of Nutrition, University of Jordan. So it's our pleasure to have you, Dr. Hala.
Good morning, all, and thank you for being part of the Jordan Nutrition Innovation Lab. Today, I will talk about the current evidence from Jordan regarding to the comorbidities associated with the overweight and obesity among adolescents. So regarding to the global scenario related to the overweight and obesity, according to the World Health Organization, the global prevalence of obesity nearly tripled between the 1975 to 2016, and globally also more than 340 million children and adolescents within the age group 5 to 19 years of age were overweight or obese, and in 2020, 390 million children less than age of 5 years were overweight or obese. So most of the population living around the world kills from overweight and obesity rather than by the underweight or malnutrition. So regarding to the scenario in Jordan, according to the World Obesity, around the 21 percentile of boys age 15 to 18 in Jordan are overweight and 10.2 percentile are obese. Among Jordanian children aged 6 to 12 years of age, around 19.4 were overweight and 5.6 percentile were obese. In the neighborhood of the Kuwait, the prevalence of overweight and obesity much higher, reaching to 60.4 percentile. For most of the children and adolescents are overweight or obese, and the less prevalence were in Algeria. So based on that, it's estimated that about 10 percentile of school-age children are overweight or obese, and so are more likely to be likely to have, for example, metabolic comorbidities associated with the type 2 diabetes mellitus, insulin resistance, hypertension, dyslipidemia, and stroke. So regarding to the statistic from Jordan, the national obesity risk regarding to the Jordan, it achieved about 7.5 as a score out of 10. And regarding to the childhood obesity risk, it's achieved 8 out of 11. The prevalence of obesity increased the most in Jordan over the last 2 decades, going from 27 percentile to 35 percentile. On the other hand, overweight rates among children under the age of 5 years increased by 2 percentile, skipping from 5 to 7 percentile. And as we know that obesity is considered one of the main risk factors associated with the glucose abnormalities, and the deterioration of beta cell function among children and adults is considered or much faster than the adult. Therefore, the lifestyle identification through the follow-up testing is necessary to at least revert them to the normal glucose tolerance test. Based on that, we conducted a case control study trying to measure the impaired glucose tolerance and impaired fasting glucose among a group of obese and normal body weight adolescent student aged 15 to 17 in Amman, and the sample selected randomly from private and public health school. The fasting plasma glucose and fasting lipid profile, in addition to the blood pressure, were obtained from all of the participants. And after that, the OGTT test also was performed among all participants. As you can see that, interestingly, that obese female participant had a higher level of impaired fasting glucose tolerance compared to the normal body weight. However, there were no significant differences regarding to the male between obese and normal body weight male participant. On the other hand, both obese male and female participant had a higher impaired glucose tolerance compared to the normal body weight. You can see that it's regarding to the obese female, about 50 percentile of them had impaired glucose tolerance. And the black column, it reflects the combined glucose intolerance. Based on this data, about 63 percentile of the obese participant had a combined glucose tolerance test, meaning that the adolescents with the impaired fasting glucose should undergo the OGTT. On the other hand, this table also compared the lipid profile between the normal body weight and obese individual, between male and female. So as you can see that both obese female participant and obese male participant had a much higher level of the triglycerides level and the much lower level of the high density lipoprotein. Another study trying to examine the level of perinatal perception and stress among parents having obese or overweight children aged 7 to 12 years. The data were obtained from so the data obtained from the south of Jordan, especially from Aqaba. A cross-sectional design study was conducted in 2017, and the data have indicated that the prevalence of obesity and overweight among children was 7.5 percentile, and the prevalence in private was 8.3 compared to just 6.5 among adolescent students in public health school. Also, the data have indicated that there is a positive relationship between the father's body weight, mother body weights regarding to their children body mass index, and there were a negative relationship with a significant association regarding to the having a higher level of education and regarding to the their children body mass index. Based on that, overweight and obesity are becoming a health problem among children in Jordan, and as you can see that the trend regarding to the overweight and obesity is alarming in Jordan. Another study trying to assess the eating habit among adolescents in Jordan. The sample was, or the design was a cross-sectional study, and the data indicate that more than 27 percentile of the male and 15.6 percentile of female consumed fast food more than 3 times per week. And also more than 2/3 of them consume the sugar-sweetened beverage more than 3 times per week. Unfortunately, less than 1/3 of the adolescents participant ate breakfast, vegetable, fruit, and a drink. And these results are completely inconsistent with the World Health Organization global strategy for diet and physical activity recommendation, which always recommend to achieve energy balance and healthy weight, to limit the energy intake from total fat and shifting from saturated to monounsaturated, to limit the intake of free sugar and added sugar, to limit the salt consumption from all sources, and finally, to practice physical activity not less than 30 minutes per a day, and nowadays it's already translated to achieve not less than 10,000 steps per day. Another cross-sectional study trying to assess the macro and micronutrient intake among adolescent students, and the sample was the same cross-sectional study where the around 400 adolescents, male and female participants, randomly selected from private and public school. The data have indicated that both male and female showed a low intake of the fiber, omega-3, omega-6, vitamin B1, 2, 3, 6, biotin, vitamin D, E, K, in addition to high intake of protein and carbohydrate as compared to the dietary reference intake. And the finding of this study maybe highlight that there is an urgent need for action planning to overcome the malnutrition among adolescents in Jordan. Regarding to this research work, it's regarding to the sugar-sweetened beverage contribute significantly to college student daily calorie intake in Jordan. Soft drink are not the major contributor. And as we know that regarding to the sugar-sweetened beverage is considered like a calorie-dense beverage associated with the poor diet quality. And according to the World Health Organization, it's strongly recommend to reducing the intake of the added sugar to overcome the obesity and overweight. And regarding to the definition of the Center for Disease and Control Prevention, the sugar-sweetened beverage defined as any drink with added sugar in the form of the table sugar or on the high fructose corn syrup. Several scientific evidence confirm that the high consumption of sugar-sweetened beverage is associated with weight gain and obesity among children and obesity. And this is a point, it's not surprisingly. On the other hand, another scientific evidence also indicate that a reduction in intake of 1 serving of sugar-sweetened beverage per day over, for example, 6 months is associated with a reduction of about half a kilogram of body weight and about 0.7 kilogram weight across 18 months. Also, as you can see that regarding to this point that the adolescent student is more frequently consume the hot drink, more than 4 serving size per day, which is contributing to around 180 calories per day. And as you can see that the soft drink, it doesn't consider as a major contributor for the total kilocalorie. And shifting to another table, it's trying to make an association between the calorie consumption from sugar-sweetened beverage and body weight parameters. And as you can see that the body mass index and waist circumference increase once the calorie from the sugar-sweetened beverage increase. For example, regarding to the part 2, the total kilocalorie provided by the sugar-sweetened beverage, it can be reached to less than 500 kilogram. And regarding to the part 3, the total kilocalorie provided by the sugar-sweetened beverage is greater than 500 kilocalorie. So by increasing the total kilocalorie from sugar-sweetened beverage, you can see that the body mass index and waist circumference also increase. Regarding to the last research work, it's focused on trying to assess the attitude and perceived barrier toward the healthy lifestyle behavior in Jordanian adolescents. And the data of this study is based on the baseline data from a randomized control trial trying to assess the attitude toward the healthy lifestyle behavior. And as you can see in general, regardless of the gender, that most of the adolescents participants didn't view the healthy food in a positive light. On the other hand, regarding to the male, which is reflect the blue line, most of them agree that the healthy food may be or have a positive contribution in their life. Just there is an exception regarding to the this point that the female adolescents participant totally agree that eating a healthy food make them feel better. So what are the take-home messages? In Jordan, the rate of obesity among children and adolescents is alarming as the dietary pattern and physical activity have changed dramatically due to the westernization. And we are estimated that if there is no preventative measure not taken, also the prevalence of overweight and obesity among adults will be increased. And also we still need a well-defined programs to control and prevent obesity, as well as intersectoral action are urgently required to reverse the current trends. Public health initiative for primary prevention of obesity in children and adolescents remain the cornerstone to fight the continuous rise of obesity and overweight. And as we know, as the first step in developing successful intervention to empower the adolescents to adopt a healthy lifestyle behavior is to understand the barrier toward adopting this lifestyle behavior. And finally, it's necessary to provide a health education in school classes, improving schools' facilities tailored to exercises performance. Thank you.
Well, thank you very much, Dr. Nawaiseh, for your talk. And now we'll have about 10 minutes for questions. We'd like to thank all the speakers. So if you have any questions to the three speakers, we'll be happy to take more questions. Yes?
My question for Dr. Al-Nawaiseh. One of the results you reported that impaired glucose tolerance among men, either when you compare according to body mass index, the normal and the obese men, you find no significant difference. While when you compared the normal BMI and obese females, you find a difference, a significant difference. Can you please explain why this reported in your data, or what kind of results you find?
Yes, thank you for your question, Dr. Nahla. One of explanation regarding to this point may be related that when we assess or classify the adolescents regarding to the normal body weight and obese individual, and we already excluded the overweight participant, we use just the general scale body mass index calculated by measuring the height weight divided by the height square. So, and usually we consider that the body mass index is not an accurate indicator to assess those participants. And as we know that maybe two individuals classify as obese individual, but one of them, this obesity as increase the fat mass, and the another one maybe the muscle mass. And this is maybe one of the explanation that maybe the muscle mass is greater among male participants.
Did you make any stratification for them according to age?
Yes, but I didn't reflect the result. And I think that the age group, it's very short. It's just from 15 to 17, so there were no significant differences.
Okay, the last, did you take any body mass index analysis?
Yes, we just use the one measuring the weight and the height, and for this age group we use the Center for Disease Control and Prevention growth chart, because the age group is less than 20. So we use the percentile.
Body mass, not the body mass index alone, I mean the body composition analysis.
No.
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 Okay.
Yes,
so
we use the simplest way to assess them.
Yes, yes. So I think this is the point why there is no significant difference.
Yes.
Yes. Thank you.
Thank you.
Thank you. Any other questions? There is one right there in the middle. By the way, online, if you guys have any questions, for those of you who are online, please feel free to type in your questions and we'll take them here on the device. We have a very smart device here in front of me. They gave it to me, so I'm not going to take it home, by the way. Okay.
Hi.
Hi.
Sorry. My name is Rula Abu Dawood. I'm one of the students of Dr. Hala Nawaiseh. I wanted to ask her, in the adolescent stage, I feel like most of my family members and even me, we got a little bit like overweight and maybe a little bit obese. But once we've grown up, we've grown out of it. Like most of us did grow out of it, but my older sister didn't grow out of it. She became obese. So can we consider like obesity and overweight in this age group? Can we consider it an indication of future obesity? Although it, like, for most of us, it didn't happen, but like for my elder sister. So is it a strong indication for future obesity, or is it not? What do you think?
Yes, based on the large number of scientific evidence data, the genetic predisposition play an important role. And also, when I mentioned the first study, we also ask about the family history of type 2 diabetes mellitus, family history with obesity and hypertension. And maybe I didn't show the result. A high level of obese individual, the same, there is a significant association with a family with a type 2 diabetes mellitus with obesity. So yes, the family history of obesity, type 2 diabetes mellitus also, and also the overweight and obesity during the childhood, it's maybe give a green light. If there is no management and controlling during this period, it may develop to the obesity later on.
Yes. Thank you so much.
Yes, thank you.
Thank you. Other questions? Then I will ask a question. Then my question to Dr. Odeh, actually, you talked about obesity in pediatric population. So in general, and I apologize if I missed that, how do you compare obesity between pediatric population in Jordan and adult population? So who is in more worse scenario, let's say?
Okay.
Yeah, it's working.
Yeah. Well, can you hear me? Yeah. What? Yeah. Now it's working.
Yep.
Yeah. So what we are seeing in our clinics is that the prevalence of pediatric population coming to us because of obesity is increasing. So most of the time in the pediatric endocrinology clinic, we have like short stature, sometimes failure to thrive, that people are not gaining weight properly. But in the last like 5 to 7 years, we are seeing more and more of obese children coming to our clinics. Now, in terms of comparing them to the adult population, I don't deal with adults. But if we see in terms of complications, yes, we see now insulin resistance, type 2 diabetes in pediatric population, in adolescents mainly. We see hypertension in adolescents, high cholesterol levels, obstructive sleep apnea, tremendous in patients who are under 18 years of age, because of obesity. So in terms of, if I want to compare them as complication-wise between pediatrics and adults, they have this comparable complications, so it's serious. And if I want to add to Dr. Nawaiseh, being a child who is obese is a risk factor of being an adult who is obese. So that's why we have to work on it from the beginning. And the degree of obesity and how young you present with obesity is also a risk factor into going into being an obese adult. So I think what we are going to see now is more obese adults than what we have right now, because we have now more obese adolescents if we don't interfere timely.
Thank you. One question online actually just came for Dr. Asma. What is the best screening test to detect gestational diabetes in MCH centers for pregnant women?
The best is to start prenatal, to pick up the ladies who are obese, to offer them 75 gram to our test. If it was above 140 gram, 140, so they are high risk for gestational diabetes.
Okay.
If we miss that, upon presentation to the clinic, we need to do that. If it is normal, doesn't mean that all through pregnancy women will be normal. So we need to repeat it in the second and third trimester depending on, say, the PMI of the woman, pre-pregnancy, during pregnancy, family history, previous GDM, etc.
Okay, thank you very much. I think for the sake of time, otherwise they will be angry on me. So we have to finish the session. Would like to thank you again, our speakers. Thank you very much for your listening. Thanks.
Thank you very much, Dr. Qusai.